All right, welcome to The Explainer. Today, we are tackling a topic that is absolutely guaranteed to show up on your NCLEX, anti-hyperlipidemic drugs. We're going to build the ultimate study guide, breaking down exactly what you need to know so you can walk into that exam feeling totally prepared. Let's get into it.
So let's kick things off with this question from a cardiologist. And it really hits home, doesn't it? Why wait until they see me in the cath lab after a heart attack to treat their lipids? This is why this stuff matters. We're not just treating lab values, we're trying to prevent something catastrophic from happening down the line.
Okay, so here's how we're going to break it all down. We'll start with a patient case, assess the situation, look at our drug toolkit, dive deep into statins, handle some tricky cases, and then, most importantly, wrap it all up with your role as the nurse.
All right, Section 1. Let's meet our patient. Putting a face to the problem really helps make all this information stick.
So this is ML. She's 63, has mixed dyslipidemia, hypertension, and a family history of early heart disease. Now her profile is, well, it's classic. This is the kind of patient you're going to see all the time in clinicals, and for sure this is the kind of scenario the NCLEX loves to test you on.
So what are we actually fighting against here? It all comes down to this one word, atherosclerosis. Think of it like this. Your arteries are like pipes, and over time, gunk, these fatty plaques, starts to build up on the inside. Those pipes get narrower and narrower, less blood can get through, and that's what leads to coronary artery disease, heart attacks, you name it. This is the enemy.
Okay, so we have ML's story. But how do we turn that story into a concrete plan? Well, it's a two-step process. We got to look at the labs, and then we have to calculate their actual risk.
All right, stop what you're doing and burn this table into your brain. These are the numbers you have to know for the NCLEX, no question. The easiest way to remember? LDL is the lousy cholesterol. You want it low. HDL is the healthy cholesterol. You want it high. It's a simple little mnemonic, but trust me, it works.
But here's the thing. We never, ever look at lab numbers by themselves. That's just one piece of the puzzle. The next and super important step is to plug everything into a tool like this ASCVD risk calculator. We take their age, their labs, their blood pressure, all of it, and it spits out a percentage, a number that tells us their actual 10-year risk of having a heart attack or stroke. And that number is what drives our whole treatment plan.
Okay, so now we know the problem and we've put a number on the risk. So what are we going to do about it? Let's open up our pharmacological toolkit and see what we've got.
This right here is your high-yield, need-to-know chart for the NCLEX. You should definitely recognize all these classes, but if you're going to focus your energy anywhere, it's on that top line, HMG-CoA reductase inhibitors. We just call them statins. They're the big guns, the first-line choice, so knowing those generic and brand names is non-negotiable for your exam.
All right, let's do it. Time for a deep dive on the MVPs of lipid-lowering drugs, the statins. Seriously, if you know one drug class inside and out for this topic, make it this one.
So how do these things actually work? It's pretty cool, actually. Imagine your liver is a 24/7 cholesterol factory. The main power switch for that factory is an enzyme called HMG-CoA reductase. What a statin does is it walks in, finds that switch, and flips it to off. Boom. Not only does cholesterol production grind to a halt, but the liver then goes, hey, wait a minute, I need some cholesterol. So it starts pulling all that bad LDL cholesterol out of the bloodstream. It's a brilliant 2-for-1 deal.
Okay, NCLEX alert. This slide is huge for patient safety. Yes, statins have some mild side effects like headaches or GI upset, but you have to know the two big, scary ones. First, rhabdomyolysis. Think severe muscle breakdown. The key signs your patient will report are deep, unexplained muscle pain, and the classic sign is dark, tea-colored urine. Second is hepatotoxicity, or liver damage. You're looking for jaundice, yellow skin, yellow eyes. If you see signs of either of these, it's a major red flag. You need to act immediately.
And here's another NCLEX favorite, drug interactions. There are a few, but the one they absolutely love to test you on is grapefruit juice. I know, it sounds weird, right? But here's why it matters. Your body has this enzyme system, CYP3A4, that's responsible for breaking down certain statins, like atorvastatin and simvastatin. Well, grapefruit juice comes along and completely shuts down that system. So the drug doesn't get broken down, the levels in the blood skyrocket, and the risk for those scary side effects like rhabdo goes way, way up. So no grapefruit juice.
But, it's not always so simple. Patients are complex. The NCLEX knows this, and it will test your clinical judgment. So let's level up and look at a trickier case.
Okay, meet RJ.
Right off the bat, we've got two big problems here. First, he's tried a statin before, simvastatin, and it gave him muscle pain. Red flag number 1. Second, he's on ART for HIV. And some of those drugs, the protease inhibitors, are huge inhibitors of that same CYP3A4 enzyme system we just talked about with grapefruit juice. So we've got a massive risk for a drug interaction here.
So here's the question, and this is exactly how the NCLEX would frame it. RJ needs a statin. But given his history and his other meds, which one is the safest choice? This isn't about just memorizing a drug name. It's about putting all the pieces together. What do you think?
And the answer is pravastatin or pitavastatin. And the reason why is all about how they're metabolized. These two statins are different. They don't really use that crowded CYP3A4 highway. They take a different route. This means they're not going to compete with his HIV meds for breakdown, which makes the risk of a toxic interaction way, way lower. It's a much safer choice for RJ.
Okay, great. So now, the most important part. Let's bring it all home and talk about your role as the nurse. We're going to use the nursing process, ADPIE, to structure all this, just like you would in the real world and on the exam.
So, assessment. What do you need to do? First, check for contraindications. Is the patient pregnant? Statins are a huge no-go, category X. Do they have active liver disease? Can't give it. Then you get your baselines. Vitals, weight, and super important, baseline liver function tests. You also need to ask about their diet, right? It all starts with a solid assessment.
Next up, diagnosis. Based on what you found, what are the key problems? Well, there's always a risk for injury because of the side effects, and almost always there's deficient knowledge. Most patients don't know this stuff inside and out. These diagnoses are what shape your whole plan of care. And now for implementation, which is really all about action and teaching. A few critical NCLEX points here. 1, we usually give statins at night. Why? Because that's when the body's cholesterol factory is working overtime. 2, your teaching is everything. You have to tell them, if you have any weird, unexplained muscle pain, you need to call us right away. And of course, you have to teach them about the grapefruit juice thing. It's on you to make sure they're safe.
You know, at the end of the day, a huge part of being a great nurse is being a great teacher. When we can take something complex, like a risk score, and explain it in a simple way, we empower our patients. They stop being just a patient and become a partner in their own care. And that is so, so powerful. So I'll leave you with this to think about. What's one single thing you learned today that you can use to make your patient teaching just a little bit better tomorrow?